Welcome home to USA Global TV and Radio, a place where dreams take flight, with authentic storytelling, diverse perspectives and meaningful conversations, where global stories unite and bridges are built beyond all borders. Discover world-class education, entertainment, hope and inspiration. Together, we're building bridges worldwide. Subscribe to our channel, USA Global TV. Download our app, USA Global TV. Be our guest or join our team. Visit usaglobaltv.com. Thanks to our founder and executive producer, Dr. Jacqueline Kerbeck. Music score by Yeffy Tang from Cloud Road Music. Voiceover artist Mike Porter. Creative direction by Paul Garcia. USA Global TV and Radio, your home for global connection. All rights reserved. This video and its contents are the exclusive property of USA Global TV and Radio. Unauthorized use, duplication or redistribution in any form is strictly prohibited.
Well, hello, everyone. Welcome back to the show, The Compassion Project. I'm your host, Dr. Danielle Lord, or your hostess, rather, Dr. Danielle Lord, where we spend some time really diving into what I call institutional trauma, the trauma that exists within our world. It's all around us, and we cannot begin to heal from it until we understand that it exists. And so that's what we hope to do on this show, so that we can ignite a compassion evolution. And I am so excited to be joined by my friend, Dr. Christopher .Kodama today, where we're going to be talking about humanity in healthcare, what's really going on in healthcare, what's really going on with physicians. And so joining me now, my good friend, Dr. Christopher .Kodama. So great to have you this morning. And I apologize to everyone if I get distracted. There's some type of cat fight going on outside on my back deck, quite literally. So welcome, Christopher. How are you today?
I'm great. Thanks, Danielle. And thank you for having me on today. I'm looking forward to the conversation.
Me too. And so, in just full transparency, Christopher and I not only are friends, we are colleagues together in a consulting consortium, and we're also doing some collaborative research with also Dr. Maria Granzotti and Dr. Susie Gatto-Lode. Thank you. I knew I was going to mess that up. Thank you for being there to correct that. Clearly, the cat fight outside is keeping me distracted here. But so Christopher and I engaged in some research with physicians, trying to better understand the stress that they experience as they transition into the dark side, as it's commonly referred to. So joined by Christopher today, you experienced going to that dark side as well. So why don't you share a little bit about your background, Christopher, what got you here, your transition from physician clinician to physician leader to now physician consultant?
Thanks, Danielle. So I am a pediatrician by background, and actually what drew me to the profession of medicine and pediatrics specifically was a strong desire to advocate. And the pediatric population appealed to me because you're oftentimes working with caregivers and advocates for this population as opposed to the patients themselves, unless perhaps they're older. So it really was a great outlet for that connection to purpose. And then when I selected my specific specialty, I moved into pediatric hospitalist medicine. And in retrospect, I think one of the reasons why I did that is I really enjoy creating clarity out of chaos. And as a pediatric hospitalist, you're oftentimes tasked with juggling multiple patients every day, their families, all of the specialists, and transforming and synthesizing all of those inputs into customized and cohesive care plans for each of your patients. So it's almost like an air traffic control type of a person to kind of keep everything moving smoothly and coordinated to get the best possible outcomes for the patient and family, and then to also enable the care team, specialists, nurses, et cetera, to do what they do best, which is to provide that healing care. So when I was approached with my first opportunity to step into a more formalized administrative role as a pediatric hospitalist, one of the common themes between my clinical practice and the administrative opportunity was, again, this opportunity to create clarity out of chaos. And what I also came to appreciate and realize through that transition into more of a focus on administrative and management activities was, in a way, another common theme that translated between my clinical practice as a hospitalist and managing complex administrative projects is not only creating clarity out of chaos, but you have to be paying attention to the entire system. And in the clinical space, it was the different physiological systems of the patient. In the administrative space, it's sort of its own organism. So understanding the different corporate systems, ranging from corporate support services, different departments and divisions, et cetera, and connecting those dots in such a way that you can transform that into a relatively clear, actionable set of steps to kind of propel things forward. And so over time, I really found that having that administrative outlet gave me an opportunity to practice those skills to impact at scale. I did ultimately decide, because I felt like doing clinical work, doing administrative work, and balancing that with personal life was a lot. And I didn't want to find myself in a situation personally where I was doing a lot of different things marginally well. I wanted to focus a bit more and ensure that I was doing at the top of my game every time. So made the difficult decision of transitioning away from clinical care, though I still maintain my certifications and go through all of the continuing medical education activities. But spent several years, more recently in my career over the past 20 plus years on the administrative side, went back to business school to enhance my fluency in business concepts and whatnot, and have worked primarily on the healthcare provider side in healthcare administration before ultimately a couple of years ago deciding it was time to take those passions around creating clarity out of chaos, applying systems thinking to connect dots, and being able to translate all of that into actionable plans and results. And the vehicle that I have chosen to do that through is the consulting practice that I launched, Everspark. And that's how we came to know each other. So here we are.
That is indeed how we came to know each other. So great. Yeah. Can you take a little bit of time and explain, because hospitalist is a generally new role within hospitals. I remember, I'm going to embarrass myself here for a minute. When I was working in a hospital as a senior director, we were hiring our first hospitalist, and he was a DO. And my initial thought was, we're hiring a hospitalist. Why an eye doctor? So yeah, different two different types of DOs, but so explain a little bit about the hospitalist role. And I'm curious, as you mentioned, kind of being the catalyst that brought kind of everything together to provide clarity. Was there ever any tension between you as the hospitalist and the physicians? And now that when the physicians come in, attending physicians, the specialists, was there ever any tension around that?
So I would say generally no. I mean, I think it somewhat depends upon the cultural climate of an organization and its medical staff. We, in many ways, as hospitalists, so yes, it is relatively newer, though. Time flies. I think it's been a little bit more time where hospitalist medicine has existed on the adult side than on the pediatric side. I actually discovered years later that the pediatric hospitalist program I had joined at Mary Bridge Children's Hospital in Washington State was perhaps the oldest pediatric hospitalist program in the country now. It's one of the original programs. And I'd say the tension was probably less between the hospitalists and the specialists, because in a way, the hospitalist could serve as additional eyes, ears, and hands on the hospital inpatient units when the specialists were off attending to other activities like clinic, et cetera. So there was a degree of confidence and trust that's built over time, to know that we have a comprehensive team. We've got eyes on the patient, the ability to intervene and activate plans much faster. Periodically, there might have been differences in opinion about clinical diagnoses or what to do in a particular situation, but never to the degree in my own personal experience where it impeded the ability to effectively deliver care. I think in the earlier days of hospitalist medicine, in essence, the hospitalist was starting to supplant a portion of work for the general pediatrician, who often, under a conventional historical model, would come to the hospitals, round on their patients in the hospital, go to their clinics, and then come back in the evenings to round on their patients. Anybody who was admitted during the daytime, it was oftentimes the nurses that got those patients admitted, and then calling the doctor in their clinic to get admission orders and whatnot. So when you introduce hospitalists, now you kind of split those functions apart. And so I think the primary care doctors who used to come and round on patients in the hospital were now finding themselves in a situation of, how do I maintain that relationship with my patient? If somebody else who's not part of my practice necessarily is taking care of them. And obviously, this is just one model of how this plays out. So, there were some, from a change transition perspective, I think that there were some colleagues who were used to rounding on their patients in the hospital that found it a little harder to let that go. There were, on the other end of the spectrum, those who were really relieved because it saved them a lot of time, allowed them to focus on the patients in their clinical practice, and
Mm.
and those in the middle who kind of negotiated the fine line of still wanting to come into the hospital. And we used to, the new terminology, social rounds, kind of came up, where they weren't necessarily writing orders that could very well be contrary to what the hospital's plan was, but coordinating with the designated hospitalist and cultivating those types of relationships where there would be a clear handoff. And as an example, it was not unusual for me, particularly with more complex or intense cases, to periodically call the primary care provider during the hospital stay to provide them with updates and to stay coordinated for a couple of reasons. One of them being, professional courtesy, certainly. Number two was, building that continuity of care so that when the patient was discharged, there was knowledge transfer that had already been occurring so that the receiving provider was ready. And the third was to make sure that we were talking from the same sheet of music when it came to interacting with the patient's parents and caregivers, because it was not to anybody's advantage for me to be promoting one course of action and for the primary care provider to not be in the loop and inadvertently end up promoting an alternative or conflicting course of care. So I'd say, to the extent that tension existed, that's probably more where it resided, Danielle. And even then, it wasn't overwhelming, and it certainly, maybe I was just fortunate, but it didn't seem to ever impede on the quality of care.
Nice. Yeah, I can definitely see where it could be very chaotic, right? If you weren't bringing that clarity through the enhanced relationships that you speak of. So, and then definitely getting into a lot of additional tension then with the patient, who now suddenly is getting conflicting orders and conflicting information as a result of that. So that was a great explanation of the hospitalist role. Thank you. And I think that it must have in some ways been a lot of relief for many of the physicians who, as you explained, came in the morning for their rounds, and then they saw patients all day, and then they came back in the evening. And I think that really gets into the role and the number of hours that most physicians put into their work that is kind of unknown and behind the scenes. And we certainly know that physicians put in tremendous amounts of hours, and we're seeing that squeeze still happening as they're being asked to see even more and more patients and write more and more reports and more orders throughout the day. So yeah, what a great role. I just, on a side note, I had my tonsils out at Mary Bridge, and so did both of my daughters. So well, very familiar with the Mary Bridge, at least tonsillectomy program. So yeah, it's been around in Washington for a long time, that's for sure. So in your work now with EverSpark, your consulting practice, you're doing some work around disruptive physician behavior. And I have been thinking a lot about this term, and I think it's a term that does a lot of damage to, I think, the physician role, but I think anyone even outside of healthcare, any employee, right? We see disruptive behavior occurring, and it doesn't matter what role, what title you have. But words are powerful, right? And so we hear disruptive physician behavior, and all of a sudden there's this mental image or mental thing that comes to mind around what that must be. Oh, the physicians, they're just spoiled and they want their way, right? It's kind of, I think, what is conjured up when you say disruptive behavior. We got to change that word. I think that it's not doing anyone a good service by calling it disruptive physician behavior. So you just want to throw that out and get your thoughts around that, because I don't think we're helping people understand what's really going on in terms of the trauma that physicians are experiencing as part of their work, particularly as they are transitioning into some of these additional roles as healthcare transitions.
Sure. So part of my career has presented me with ample experience and many opportunities to deal with physicians who may be struggling either in the manner in which they're delivering care from a clinical quality and outcomes perspective, as well as from their behaviors. And so fast forward to the consulting practice, surprisingly, because part of what I do includes public speaking, this particular topic seems to captivate a lot more interest than some of the other things perhaps that I would present on, which has been really interesting. And I think you referenced this notion of what happens behind the scenes. This, in some ways, is a bit of a black box and somewhat of a mystery to folks, depending on where they sit in a relationship to where their clinical practice is, if that is in the hospital or in an ambulatory environment. I did not coin the term disruptive behavior, certainly not the physician disruptive behavior. I do agree with you. It can mean a lot of different things to different people. And the term disruptive in this context is largely relates to kind of more of an HR, human resources orientation to it. Like the definition of disruptive physician specific behavior is any behavior that creates or it impedes the ability to deliver well coordinated quality care to a patient, in essence, or an individual. And so that could take the shape of verbal abuse, even tacit abuse, like blackballing and alienating people, to the more dramatic things that sometimes come into people's minds, like throwing of objects or shouting at somebody, physical intimidation, those sorts of things. So that's kind of the context in which those discussions kind of reside. But as you're alluding to, I think that it can be um, more broadly applied beyond that specific scope of the HR considerations to, is this disrupting the ability, for example, of an administrator to complete a task or move a particular agenda or project forward? And that's something different in my mind, where, as I think about this question, I've oftentimes felt that being a physician, kind of being on that inside, I may be less aware of how physicians are viewed by non-physicians. And, I can't go back in time and before I became a physician to kind of test that. But based on signals and cues from non-physician colleagues, I think sometimes physicians can come across as very intimidating. Um, and whether that's through their demeanor or their behaviors, you really is highly dependent on the dynamic and the situation, uh, to things that have nothing to do with the individual person, but are sort of the stories that the non-clinician is telling themselves around, well,
Mm-hmm. Mm-hmm.
spent a lot of time in school and worked really long hours and therefore must be very smart and perhaps smarter than I, which is not, I don't think that's the way that physicians think about it. Like, I'm smarter than you. We are immersed and trained in such a way that we have to amass a significant amount of knowledge, though that's a conversation for another time as we think about knowledge management and um, information overload and with amplification
Mhm.
studies and other sort of guidance and sources of information for physicians and for patients and their families kind of takes us down an entirely different path about stressors
Yes,
for
yes.
clinicians to stay on top of things. But so that's kind of my initial reflection on the terminology around disruptive. And I completely agree with you. Disruptive behavior, a lot of the examples that I provided earlier around verbal and physical abuse, for example, um, those are universal across any type of role. What I have been asked to opine on and provide tips and tricks on managing is there are some nuances of how disruptive behavior or the type of behavior that impedes well coordinated quality care uh,
Mm.
may manifest for a physician, specific considerations and context, which should not be mistaken as excuses for the behavior, but can provide some insights about the etiology of the behavior and perhaps some insights on how to go about managing and adjudicating the consequences associated with the behavior.
Yeah, I think a couple things come to mind through that conversation, and you're right about there's this kind of general perception that it's a physician, so therefore I'm maybe a lesser informed, not as knowledgeable. Therefore, I'm putting this individual on a pedestal. But we also see this really crazy compressed time format that physicians have to interact with a patient. And it's 6 to 9 minutes, something to that degree, and I might be a little bit off on that. That's not a lot of time to come in and connect with you on a deep relationship level. And so I think that sometimes can cloud the judgment of how people perceive physicians, is that, well, they're just in and out. Yeah, that's kind of the way the structure is set up, as unfortunate as it is. So it's difficult to gain a relationship. And I think back, to 50, 60 years ago, right, you had a physician from childhood to old age. And so you had the opportunity to really get and develop a relationship with your physician. And I had another thought, and it's gone, but it'll come back. The values, I think, is where we really begin to see that behavior come out. And this is a very generalized application as well, because I think anytime we push up against an individual's values, we are going to see some disruption, and we're going to see some behavior that can sometimes be like, whoa, where'd that come from? So I think about my husband. In his role, in his background, quality is probably his number one value. And so in the workplace, when people push up against that and they fudge numbers or they let things slide from a quality perspective, he goes a little off and has some disruptive behavior. So I'm thinking in terms of how, as a physician, I think probably most physicians went into this work from an altruistic perspective, right? You want to give, you want to heal, you want to care. And I think that might be true of anyone with a terminal degree. I know just from my own experience going into my PhD cohort, there were probably 20 of us. And of those who said, I'm doing this, that was the first question. Why are you here? Why are you doing this? And for those of us who said, I'm called to do this, I want to contribute to knowledge, I want to participate in the greater good, versus those who said, I'm here because I want to make lots of money. Guess who washed out and guess who finished? And you probably the same, I don't know, Dr. Jacqueline weigh in, our show producer, as a DBA, Doctorate of Business Administration. You might have had a similar experience. Physicians might be slightly different, though, because of the amount of pre-work that's done, right? You go through several different interviews, so they make sure that the physicians are probably not likely to wash out as quickly. But the point of that story is to say that I think we go into this work because we want to give, we care, we have some type of altruistic value, right? Whatever falls into that bucket. And so I think anytime that we have work that pushes up against those values and our sense of calling, it shows up as behavior, whether that's disruptive or throwing things or pouting or going to your shadow side or whatever that may look like. So I think, the bigger conversation is, do we call it something else? Because I think just calling it disruptive behavior, whether it's a physician or anybody else, is really doing a disservice, I think. And I think just piling on more stress, more trauma, more frustration, because now we're labeled and now we've got to have some kind of intervention.
Yeah, that's a really interesting question, and I don't have a clear answer. What might we call it differently? I absolutely agree that words matter. And to a certain extent, I think, however, the profession navigates through this particular conversation and how they want to characterize this, I would be cautious about not throwing the baby out with the bathwater, because there really are legitimate behaviors that it's difficult to characterize them as anything other than disruptive, based on the definitions that I was talking about before from a workplace safety and patient safety perspective. And there probably ought to be terminology used that still indicate the gravitas of that. Whereas I think a lot of what we're talking about is more of that gray zone, outside of the definitive, this impacted or impeded the ability of the care team to deliver well coordinated quality care and safe care. There are a lot of gray things where it's like, is it, you and I are kind of joking around before the show. It's like if you had a bunch of flashcards and sort of reporting out specific examples, and then I would have to name, is it disruptive or non-disruptive? I think it really kind of revolves around, is it the capital D HR disruptive, or is it disruptive but not something that would necessarily warrant some type of punitive or accountable performance improvement intervention, but spurs more of a conversation. And I think one of the other things that came into my mind as I was listening to your comments, Danielle, was healthcare, perhaps compared to certain other industries, is very high stakes. Mistakes can lead to loss of life or significant adverse outcomes for a patient. And I think carrying that weight around, whether you're a physician or a nurse or somebody else, but particularly if you're hands-on patient care and clinical delivery, that's sort of a specter. Is, I can't afford to be sloppy or not pay attention to detail. And that's ingrained, at least in my generation of physician trainees, that was ingrained in us very early on. And I think when things don't go according to those high standards, that can oftentimes result in a triggering moment for physicians between themselves, as well as with other colleagues like nursing and respiratory therapy, et cetera. And is that outburst or expression of frustration disruptive? I think certainly with a lowercase d, one could make the argument that that's the case. But again, we kind of find ourselves in a gray zone where it's sort of like, I don't think we're debating the merits of whether or not a mistake was made. It's more about the manner in which we react and how that manifests in our behaviors. And so blowing off steam might make you feel better in the short term, but what has that done to the ability to function effectively with your colleagues if they're now afraid to admit that there was a mistake, or that something may have gotten missed, or to question the care plan? You've automatically created an environment in which that's no longer a safe space. And I think that that's a detriment to the ultimate outcome, which is the benefit of the patient. And so that's where I kind of draw the line about coming back to this definition of, is it impeding the ability of the care team to coordinate well, have that safe space, because that's where quality and safety are based. And if you're not talking, or if you're afraid to talk, or you're afraid of retaliation, no matter how legitimate the behavior may have been about expressing the frustration over the mistake, it still has this consequence, unintended or otherwise, that adversely impacts patient care. So that's kind of how I think about it. Now, the terminology, I need to think about that a little bit more, because I'm a big fan of what you said, that words matter. And we should have a common understanding of the language, so that what we're saying is reflective of what we mean, as opposed to using the same terms but meaning different things, or using different terms to mean the same thing.
Yeah, that was such a great explanation. And I think it's two different things, right? But to lump it all into one, I think we definitely do a disservice to either, whatever the situation is. But what a great reminder of this weight and burden that physicians and nurses and most of the clinical care team carry around is, my gosh, I could make one mistake. And it could have a really adverse impact on the patient. And, I know you can name a million. I can probably name, a good half dozen at least that I've seen from sitting in the seat where I sit as a non-clinician. So it's a very real thing. And, unfortunately, sometimes they are so bad they even make the news and the headlines. So it is a real weight that most of the clinicians carry that I think is oftentimes really misunderstood amongst the general population. So yeah, great clarity around that. So
Well, I think part of that, Danielle, just to wrap that portion up, when I think about disproportionate behavior, so the surgeon who throws a surgical instrument or something in the OR because someone did or didn't do something that they were supposed to, it doesn't excuse the behavior, but oftentimes it's because there's a genuine concern about the safety of the patient on the table in that particular example. So, that could provide some context about why was this reaction so disproportionate from what one might have thought would have been appropriate and more productive, so that you can then drill into the conversation with the individual physician to see if you can get to insight where they recognize that their concerns are legitimate and the manner in which they express those concerns needs to be done in a way that's at least neutral, if not constructive.
Wow. And tough when the stakes are high, right?
Yeah,
and you
right.
have limited amount of time. And sometimes those surgeries can last a long, long time. So imagine for surgeons, as probably as well as they can compartmentalize things, they get tired and hungry and stressed as well. So it's a great reminder. So wow, great clarity, I think, and hopefully this brings folks a little understanding of the stress that physicians are going through on pretty much a daily basis, right? And that in and of itself can be traumatic. In fact, part of the literature I was reading in preparing for the research that we're doing was talking about that very thing, that it's just kind of this daily thing, this daily grind. And this particular researcher called it a level 2 trauma. And so this idea of trauma in the workplace among our physicians, certainly, and clinicians, I should say all clinicians really, is certainly there and prevalent. So so we're doing some research, as I mentioned, and I'm excited to get some data points on this, hoping that maybe you'll come back a little later in the summer and share some of the insights that we had, because I certainly think that it will apply not only to physicians, but hopefully to leaders more in general. But what are some things you're hoping to get out of this? What are a few nuggets you're hoping to walk away with, especially as you've made this transition from clinician to leader and now consultant?
Sure. So, very different kind of view on the physician experience, toggling away from the conversation related to disruptive and potentially adverse impacts of behavior on clinical care to something quite different, but still the common thread related to the stress that we incur as physicians is this notion of transitioning to formal leadership roles. And what's one of the things that popped into my head earlier, Danielle, when we were chatting, was that there has historically, at least in most Western style medical systems, is this sort of implicit hierarchy of the physician kind of being the decision maker for clinical care. And, there's sort of then the nurses and the ancillary services and so on and so forth, which is in a way, physicians, I think, find themselves in their clinical practice thrust into sort of an informal leadership type of a role, where people are looking at them as sort of the captain of the clinical care pathway ship, so to speak. And then when those individuals transition into leadership roles for whatever reason, one very common reason for a clinician, whether that's a physician or nurse or other service provider, transitioning in a leadership role is it's a recognition of how well they've led and provided led care teams and provided clinical care, and then they move into these administrative roles, and the dynamics are sufficiently different that what served them well as clinical leaders doesn't necessarily position them for success as business leaders and on the administrative side. And so that's really, the conversation you and I started having, gosh, it's been over a year now, I think, about what does that transition look like, and how intentional or organic are we, both as the physicians going through that process as well as those hiring us into those positions. And I'll go back to one of the original conversations you and I had on this topic. Personally, I found moving into a full-time management role, I really kind of hit a wall, frankly, about 15 months in. And in retrospect and spending a lot of reflection, I could have actually peeled out and gone back to full-time clinical care and jettisoned the administrative responsibility by and large, but I chose not to. And I think part of it was due to the fact that as I sat with myself and what I was feeling, that degree of fatigue and burnout, in the clinical world, as a physician, I was practicing physician, I was used to writing a series of orders, having a conversation with the care team, and then we had a plan for the rest of the day, and we were driving to a hospital discharge in this clinical context, within a certain number of days. And this, we coordinated with care managers and so on and so forth, and social workers to make sure that we were lining everything up to minimize the amount of time that a family ended up needing to stay in the hospital. We wanted to make sure that that was appropriate for them, and then help them move forward with their recovery outside of the hospital. When you move into administrative work, I think the time cycle is very different. And what I mean by that is the decisions you make, sort of analogous to the orders that you might have written in the chart clinically, may take months to years to manifest. Not always, but there are a fair number of those things where now you're having to interact with a much more complex ecosystem of stakeholders and resources. It may be analogous to dealing with care teams and families as a clinician, as a hospitalist, but there is quite an amplified effect in terms of, what does this department think about it if I make this change to this program, and how does that impact the financials for the organization or the department? What are the HR considerations, hiring? And there's just a lot of things that at a macro level require a lot more time and energy in order to come up with an effective plan. And because it doesn't happen as quickly as what we're conditioned to expect, is that, at least for myself, I used whatever was available in my toolkit to compensate, which included longer hours and more intensity of work. But that's only sustainable for so long. And that's where I think for me, that threshold was about 15 months, where I could no longer sustain working at that pace of 80 hours a week. And I remember telling myself at the time, you've done this before in your clinical training, being on call, the 80-hour work rule was something that was just kind of being taken more seriously after I had finished my training. So, but what was different was in those circumstances, you had built-in breaks periodically. Whereas in this instance, I'm working straight through. I'm working on Saturdays. Sunday I'm just sleeping. I'm not having a life to reset my perspective for when I come back to the work. And so, not everybody, but for some, it can be quite jarring. And you're either going to figure it out on your own, or you're going to crash and burn, was kind of my experience around these types of reflections that I'm sharing now. And so what I am excited about the research that we're doing is trying to be more intentional about identifying what are sort of the key drivers for those who do experience this type of fatigue and burnout in their leadership roles, and what are potential countermeasures that can then inform preemptive interventions, so that we're more intentional on the front end about anticipating the most common pitfalls for physicians as they transition into increasing levels of leadership and administrative responsibility to reduce that fatigue and burnout, because there's plenty of other drivers out there outside of the context of what we're studying that can contribute to that fatigue and burnout. So why not pull out and take care of the things that we can actually positively impact?
Absolutely. So well said. And wow, we are out of time. And I have a million more questions for you. Thank you so much for being part of the conversation. And I hope we brought some much needed light to the role of the physician and what physicians experience on a regular basis going forward. And I'm excited to continue our research and hope to get you back on the show a little later in the year. Thank you so much, Christopher. It's been great to chat with you today. Thank you to our producer, Dr. Jacqueline, and to USA Global TV and Radio. And next month, we're going to have Aniza on the show, and we're going to be talking about generational trauma and epigenetics. So hope to see you back then. Until then, take care of yourself so we can take care of others. Thank you.
USA Global TV and Radio proudly presents Steve Klein Art at steveklein.art.
My name is Steve Klein, born Manchester, England, 1953. My quest in my lifetime is to create artwork from my soul and the deepness within my wildest dreams and fantasies. In 2012, my heart stopped when I was given too much anesthetic for a minor knee operation, and this near-death experience took me to another multi-dimensional world, an out-of-body experience, and I was given the gift of being blessed by an overwhelming, burning passion to become, for the very first time in my life, an artist with an eternal, passionate desire to bring my art, which I've named multi-dimensional, subliminal, freeform art, to the world, as only 3% recover from what I experienced, and now in my golden years want to release my cosmic, vital energy through my art to allow people to be a part of my cosmic dance.
To learn more, email roccogoodwine@gmail.com. For VIP pricing, mention USA Global TV and Radio.
Ever dreamed of hosting your own TV show, sharing your story with a global audience? Now's your chance to shine. At USA Global TV and Radio, we make it easy for you to create, host, and broadcast your very own TV show. Whether you're a storyteller, entrepreneur, or industry expert, we help you bring your vision to life. With our exclusive interview, live streaming, and podcasting training, you'll gain the skills and confidence to captivate your audience. Our global platform ensures your voice is heard worldwide. Join our community of creators who are already making an impact, one show at a time. Step into the spotlight. Host your own TV show on USA Global TV and Radio. Book your discovery call today at usaglobaltv.com. Copyright 2025 USA Global TV and Radio. All rights reserved. Terms and conditions apply. To learn more, visit usaglobaltv.com. Thank you, viewers and listeners of USA Global TV and Radio, for joining us today. We're honored to have your time and attention as part of our global community. At USA Global TV and Radio, we believe in the power of authentic conversations, meaningful connections, and creating a world of possibilities together. Want to be part of something bigger? Join our team of elevated listeners at usaglobaltv.com, a space where your voice matters and your ability to listen transforms relationships. Stay connected with us across all our platforms for thought-provoking discussions, expert insights, and empowering stories. Subscribe to our channels at youtube.com/c/USAGlobalTV. Follow us on social media and explore the endless opportunities we're creating for growth, learning, and inspiration. Together, we're not just broadcasting, we're building bridges and changing lives one conversation at a time. For inquiries, contact us at info@usaglobaltv.com. Music by Johnny Dies. Produced by Executive Producer and Director Dr. Jacqueline Kerbeck. Voiceover by Mike Porter. Creative Direction by Paul Garcia. All rights reserved. Copyright 2025. Visit usaglobaltv.com to view our full terms and conditions.